Welcome to ZRADMD, and this lecture is entitled Pulpal Necrosis Without Decay. This case was of an 18-year-old female who presented to the emergency department with upper tooth pain. The patient ended up getting a CT scan which showed a periapical radiolucency associated with the left maxillary central incisor here and here. And there's some soft tissue fullness and stranding here. Looks like an infection, looks like a periapical abscess, but if you notice the tooth, there's no decay. The enamel's intact, the dentin looks normal. There's no evidence of decay associated with this tooth. So I kept looking and I noticed a few things. One, there is a retained molar right here. It's a primary molar. You can see here there's the third molar, second molar, first molar. You'd expect there to be a premolar with premolar roots here, but there's not. This is a primary molar, and most of the roots have been resorbed. And this patient actually had this finding bilaterally. And so to retain teeth like that, it can happen naturally, but it's often done when there's an absent permanent tooth, and it's done using orthodontia. The other thing I noticed was, one, these teeth are remarkably straight, much straighter than the line I just drew. There's also thickening of the lamina dura, you can see right there. And these again are findings that this patient had prior orthodontia. So one thing that can happen with braces, so when I say orthodontia I mean braces, is you can get pulpal necrosis from ischemia just from the movement of the teeth. It's a rare complication, but it can occur. So to determine if the tooth was actually necrotic, you would have to have what's called a vitality test. And this is performed by a dentist or endodontist, and they'll either apply a really cold substance to the tooth or electrical impulses to see if you can feel the sensation. And if you can't, it implies that the pulp is necrotic. But typically, on imaging, the radiologist cannot determine pulp necrosis. So I know I just said that you can't determine pulpal necrosis on imaging, but actually in this case you can. So if you look at the two central incisors, here this is the right and left maxillary central incisors, you can see their pulp chambers and their pulp canals are different sizes. So the one on the left is larger. There are cells called odontoblasts that line the periphery of the pulp, and they continuously lay down dentin throughout one's life. When a pulp dies, those cells die and they stop laying down dentin. And so normal pulp chambers will get smaller and smaller as anyone ages. And so the fact that this pulp chamber is wider than this one, suggests that the left maxillary central incisor stopped producing dentin from the inside out years ago. And so this is indirect evidence of pulpal necrosis. But it makes sense. This patient is 18. If she had braces when she was 13 and had aseptic necrosis, that is necrosis of the pulp without infection, when she had her braces, it may have gone unnoticed. There would have been no pain, no evidence of decay. And then years later, you would see a difference in the amount of dentin inside the pulp chamber. So that's what I think happened with this case. So my final diagnosis for this case was a periapical abscess and soft tissue cellulitis associated with pulpal necrosis of the left maxillary central incisor. The pulpal necrosis likely resulted from prior orthodontic therapy. Correlation with dental history is recommended. Here is a companion case of a 14-year-old male who just got his braces off. And in fact, this was me. When I got my braces off, the orthodontist noted that my left maxillary central incisor was dark. I had no pain. There's no evidence of decay. It was just dark. And so they sent me to an endodontist who did a vitality test, put that cold substance on my tooth, and I couldn't feel anything. So it was completely necrotic. Again, there was no decay, there was no abscess, but these aseptic necroses of the pulp need to be treated with root canal therapy as if there was decay, and that's to prevent subsequent infection like we saw in the last case. So again, the tooth vitality test revealed pulpal necrosis, and it was treated with a root canal. So again, I want to review the treatment of aseptic pulpal necrosis. It's the same as if there was decay. So the tooth is necrotic, the pulp necrotic, it needs to be removed and cleaned. So it needs a root canal. But given the large periapical radiolucency that we saw in that first case, and the fact that it had been very long-standing, it's possible that cleaning the root through the tooth and through the canal may not be enough. Sometimes those periapical lesions can heal in over time, and sometimes they don't cause a problem, but when they're large and long-standing, sometimes additional therapy is needed. And that additional therapy is called an apicoectomy. So let me describe a little bit of what that entails. It's basically cleaning from the other end. So a root canal is cleaning, you go through the crown into the canal. An apicoectomy, you go into the canal but through the apex of the root. And so here you can see an incision in the gum. This is a completely different patient. It just nicely demonstrates this procedure. There's an incision in the gum down to the bone. The periosteum is elevated off the bone. A little window is made right over the tooth apex, and it's visualized. And here you can clean out any granulation tissue, any abscess, or any cystic material. And then the apex is removed, hence the apicoectomy, and then the pulp canal can be cleaned from the apex side. And this is, again, is called an apicoectomy. Not always needed, but sometimes needed when there are large periapical lesions that have been there for a long time. So I'd like to summarize the key points of this talk. One is that pulpal necrosis is a rare complication of orthodontic treatment. It needs to be treated early with root canal therapy to prevent future complications or the need for apicoectomy. If there is a periapical radiolucency involving a tooth without evidence of decay, it's really important to test the tooth vitality, and that's not something the ER doc can do or the radiologist can do. It needs to be done by a dentist or endodontist. However, if there's evidence of remote necrosis, you can infer the diagnosis. And again, that's when there is apparent widening of the pulp chamber compared to the contralateral side, and that's due to the cessation of secondary dentin formation when the pulp dies years prior to imaging. But ultimately, I want to emphasize pulp vitality is a clinical diagnosis. And finally, I just want to say, and this is in bold because it's really important, that a periapical radiolucency associated with a vital tooth should not be assumed to be an infectious or inflammatory lesion. So if you have a dentist telling you, or a clinician telling you that the tooth tests vital, that there's no decay, even if the cyst appears to be in the periapical location, other diagnoses should be considered, such as non-inflammatory or odontogenic cysts or neoplasms, cemental osseous dysplasia, vascular lesion, or other etiologies.